Orbital infectious disorders. Acute cellulitis. Types: preseptal or orbital cellulitis. Organisms: bacterial, Staphylococcus aureus, Streptococcus pyogenes. Anaerobic organisms follow bite wounds. Fungal: mucormycosis and aspergillosis. Chronic cellulitis. Types: non-granulomatous, as inflammatory pseudotumors, Mikulicz disease and Sjogren's syndrome. Granulomatous: TB, sarcoidosis, syphilis, parasites as trichinosis, Echinococcus granulosus, hydatid cyst, and schistosomiasis. Crohn's disease, cat scratch disease, midline lethal granuloma, cholesterol granuloma, and inflammatory pseudotumor. Acute cellulitis, preseptal cellulitis. This is inflammation and infection anterior to orbital septum. It is caused by trauma, direct inoculation in adults, or by spread from adjacent structures in children. Upper respiratory tract infection as sinusitis and middle ear infection. Adjacent structures from which spread can occur also include skin, as in impetigo, herpes simplex virus dermatitis, and varicella zoster virus. Lacrimal system, as in dacryocystitis and dacryoadenitis. Conjunctiva, as in adenoviral conjunctivitis, epidemic keratoconjunctivitis, bacterial conjunctivitis by Neisseria gonorrhea. Gross picture of acute cellulitis: edema and erythema of upper and lower lid, abscess formation associated with fluctuation, minimal conjunctival inflammation, no eye globe or orbital involvement. Microscopically, there is acute preseptal inflammation. Orbital cellulitis: this is inflammation affecting orbit posterior to orbital septum. It is caused by spread from adjacent structures, as in sinus infection 75%, ethmoiditis, maxillary sinusitis, streptococcal pneumonia, and H. flu. Polymicrobial nature is typical. Orbital cellulitis is also caused by trauma and distant structure spread. Grossly, there is lid swelling, conjunctival chemosis, proptosis, limited ocular motility, and visual loss due to cavernous sinothrombosis or central retinal vein occlusion. There is also ethmoidal or maxillary sinus opacification, increased visibility of orbital fibrous septae, proptosis, enlarged extraocular muscles, abscess formation, subperiosteal abscess, orbital abscess, and frontal abscess, Haemophilus influenzae. Chronic granulomatous cellulitis, sarcoidosis. This is multisystem chronic non-caseating granulomatous inflammation. It represents cell-mediated immune response, CD4 positive helper inducer T cells, to unidentified antigens. Systemic immunologic abnormalities are evidenced by energy to skin tests as purified protein derivatives. HLA genotypes: HLA-A1 and HLA-B8. Sarcoidosis affects young adults. Systemic manifestations: lung involvement, hilar lymphadenopathy 75 to 90%, interstitial pneumonitis 90%, peripheral lymphadenopathy, skin lesions 25%, erythema nodosum, raised red tender nodules in anterior aspect of legs, discrete painless subcutaneous nodules, lupus pernio, indurated violaceous plaques in region of nose, cheeks, and face. Other soft tissue involvement: spleen, liver, bone marrow, lacrimal and salivary gland. Ocular involvement 25 to 50%, eyelid nodules, inferior conjunctival nodules, and lacrimal gland enlargement. Intraocular sarcoidosis: recurrent unilateral or bilateral iridocyclitis in 25%, mutton fat keratic precipitates, secondary glaucoma. Corneal affection, interstitial keratitis or band keratopathy. Fundal affection, retinochoroidal granuloma, retinal periphlebitis, candle wax dripping, and optic nerve granuloma. Microscopic picture: non-caseating epithelioid granuloma, discrete compact collection of histiocytes, highly differentiated mononuclear phagocytes, abundant eosinophilic cytoplasm, vesicular nuclei, multinucleated giant cells, fusion of macrophages, Schaumann bodies, laminated concretions formed of calcium and proteins, asteroid bodies, stellate inclusions within giant cells, surrounded by outer zone of CD4 positive helper T cells.